A 7-year-old girl a 7-year-old girl is brought to the physician because of progressive sleepiness, ataxia, double vision for over the past 2 days. She has 2 year history of she has 2 year history of complex partial seizure treated with carbamazepine. 1 week ago, she developed fever and received erythromycin for pharyngitis. Her brother has attention deficit hyperactivity disorder treated with methylphenidate. Her temperature is 37 degrees Celsius. She appears sleepy. Ocular movements are full. She has no weakness but is moderately ataxic. Which of the following is the most likely cause of her current symptom?
Ready?
Yes.
So it's carbamazepine erythromycin interaction. Carbamazepine is an anti-epileptic medication has been shown to interact with other meds, and caution should be exercised when choosing concomitant medication for treating patients. It's a CYP450 inducer, which may increase hepatic clearance of some medications like warfarin, phenytoin, and valproic acid, leading to subtherapeutic concentration in the serum. Other drugs, such as erythromycin, can interfere with hepatic metabolism of carbamazepine by inhibiting CYP450 enzymes, leading to decreased carbamazepine clearance. Increased serum concentration and toxicity. Carbamazepine toxicity typically presents with altered mental status, drowsiness, ataxia, nystagmus, nausea, vomiting. Diagnosis can be made by measuring the serum carbamazepine concentration above the therapeutic level. There is a dose-dependent effect on neurologic depression. Treatment is supported with benzo for seizures or agitation and involve discontinuation of the offending medication. Okay.
Okay. Next. Okay. A 52-year-old man comes to the physician because of progressive bilateral pain over past year. The pain is located on the posterior aspect of the thigh and the calves, occurs only when he is standing and resolves within 30 seconds of sitting or lying down. He has noticed that the pain is less intense if he leans on something as he walks, such as grocery cart. He can still ride. He can still ride and exercise bicycle. He can still ride and exercise bicycle without developing any pain. He has hypertension, hyperlipidemia, small abdominal aortic aneurysm. He had a left carotid endarterectomy 3 years ago after several TIA in the left hemisphere. Medication include lisinopril, lovastatin, aspirin. He has smoked one pack of cigarettes daily for 30 years. He can still ride and exercise bicycle without developing any pain. He has hypertension, hyperlipidemia, small abdominal aortic aneurysm. He had left carotid endarterectomy 3 years ago after several TIA in the left hemisphere. Medication include lovastatin and aspirin. He has smoked one pack of cigarette daily for 30 years. He is 5 feet 11 inch tall, weight 110 kg, BMI 34. His temperature is 37 degrees Celsius. Pulse is 70 per minute. Respiration 12 per minute. Blood pressure 150 by 90. Examination shows right femoral bruit and diminished pedal pulses. Which of the following is the most likely cause of this patient's lower extremity pain?
Ready?
1 second. Okay.
So it's lumbar spinal stenosis. The patient symptoms are more consistent with neurogenic claudication caused by lumbar spinal stenosis. Spinal stenosis describes narrowing of the central canal, neural foramen, or lateral recesses of the spine with consequent nerve compression. Common causes include degenerative arthritis, spondyloarthropathies, degenerative disc disease, hypertrophy of the ligamentum flavum, and osteophyte formation of the facet joint. Neurogenic claudication describes lower back pain with radiation to the buttocks and lower extremity that results from increased nerve compression. As may occur with extension of the spine during standing or walking downhill, lengthening of the spinal column with spinal flexion or during sitting, walking uphill or leaning against a grocery cart tends to relieve the pain. Diagnosis evaluation involves X-ray followed by MRI of the lumbar spine to evaluate the degree of the spinal stenosis and whether surgical management is necessary. Next.
A 57-year-old woman comes to the physician because of 2 day history of dribbling fluid from mouth every time she drinks. She has not had difficulty swallowing or any other symptoms. She has no history of serious illness, takes no medication. She has an active lifestyle, vital signs are within normal limits. Examination show dropping of the lower lip on the left forehead, does not wrinkle on upward gaze. The remainder of the examination shows no abnormality. Which of the following is the most appropriate next step? Left foot,
Mm.
the left forehead does not wrinkle.
It's lower motor neuron, so it's probably left bell spasm.
Left forehead does not wrinkle.
So
Does
it's
not
lower.
does not wrinkle. Left forehead does not wrinkle on upward gaze. Yes, lower motor neuron.
So
If
is it,
wrinkling happens on the left, uh, up on upward gaze, then it is upper motor neuron, isn't it?
it here is lower motor neuron
Yes,
palsy.
yes,
So it's Bell's palsy. So
yes.
do
Prednisolone.
okay. So, okay. Let's see. Oops, sorry. Prednisone therapy. Bell's palsy refers to a facial nerve palsy that leads to unilateral facial paralysis. It's more common caused by viral mediated inflammation or immune reaction in the setting of herpes simplex or herpes zoster infection. Although it can also be idiopathic or caused by other viral infections. Presents acutely with unilateral facial paralysis that include forehead consistent with lower motor neuron involvement. And also be associated with loss of taste and anterior on the anterior two-thirds of the tongue and decreased lacrimation. Symptoms typically peak around 3 weeks with slow recovery within 6 months. Diagnosis is most commonly based on clinical symptoms, but electrodiagnostic studies such as EMG and imaging of the face and head can be used if the diagnosis is unclear. Initial treatment is oral steroids such as prednisone and antiviral therapy in severe cases. It is not doxycycline therapy can be used in the treatment of Lyme disease, which may present with Bell's palsy in disseminated Lyme disease. Lyme disease also typically presents with erythema, migraines, fatigue, headache, myalgia, lymphadenopathy, myocarditis. This patient has not the symptoms of to suggest Lyme disease. Okay, next.
A 72-year-old man comes to the physician. A 72-year-old man comes to the physician because of 1 week history of imbalance and leg weakness. 1 week history of imbalance and leg weakness, 3-day history of difficulty initiating urination. He also had mild mid-thoracic back pain. He also had mild mid-thoracic back pain for 5 months, but during the past 2 weeks, the pain has worsened and frequently awakens him. He has had 9 kg weight loss since an episode of bronchitis 6 months ago. He has smoked 1 pack of cigarettes daily for 50 years. He is cachectic and appears chronically well. Examination showed scleral icterus muscle strength in the lower extremity is decreased in proximal and the distal muscle bilaterally. There is no muscle atrophy, but the tone is increased. There is no muscle atrophy, but the tone is increased. Deep tendon reflex are hyperactive. Deep tendon reflex are hyperactive. Babinski sign is present bilaterally. Sensation is decreased. Sensation is decreased to pinprick into the umbilicus. Muscle strength, sensation, and reflexes of the upper extremities are normal. Which of the following is the most likely diagnosis? Muscles. 1 week history. 1 week history. Difficulty.
Ready?
Vasculitis.
Ready?
Mm, yes.
So it's epidural spinal cord compression. This patient presentation signs and symptoms of focal back pain or premotor signs in the lower extremity, weight loss, and are suggestive of epidural cord compression, spinal cord compression caused by metastatic carcinoma. Metastatic disease frequently affects the vertebral column and may cause compression of the spinal cord by extending into the epidural space or by causing bony destruction and fracture of the vertebral bodies. Patients present with back pain, lower extremity weakness, loss of balance, urinary and bowel incontinence, or complete paralysis of the lower extremity. Early detection and treatment are crucial to prevent permanent spinal cord damage and myelopathy. Patients may benefit from um, short-term treatment with IV dexamethasone um, to decrease spinal cord edema, although definitive treatment often requires a combination of surgical decompression and chemo and radiation therapy. If not spinal cord infarct may result from occlusion of the anterior and posterior spinal arteries and present with abrupt onset myelopathy. Neuroimaging may be required to distinguish this entity from compressive spinal cord lesions. This patient history of subacute onset and weight loss is most suggestive of compressive spinal cord, compressive epidural malignant lesion. Is not transverse myelitis refers to inflammation that extends transversely across the spinal cord, leading to bilateral sensory, motor, and autonomic dysfunction, often with clearly identifiable spinal level below which normal function is decreased or absent. It is associated with MS and neuromyelitis optica, the latter of which is associated with presence of anti-aquaporin 4 antibodies. Okay, next.
A 67-year-old woman comes to the physician because of 6-month history of buttock and 6-month history of buttock and leg pain. The pain occurs when she walks for more than 2 blocks or stands for more than 10 minutes. Sitting or bending forward provides pain relief. Sitting or bending forward provides pain relief within 1 minute. She has no weakness. She has had weakness or loss of sensation. Bladder function often sorry bladder function has been normal. She has 20-year history of lower back pain relieved with rest. She has type 2 diabetes mellitus well controlled with metformin. Muscle strength is full. Tip tendon reflex are 2 plus except for absent ankle reflex. Sensation is intact. There is decreased lumbar lordosis. Lumbar flexion is full and extension is limited. SLR is negative. Peripheral pulses are intact. Which of the following is the most likely diagnosis? You will leave early today, isn't it?
Yes, in less than an hour.
Oh, sorry.
No,
We
it's okay.
wasted time in five
No,
minutes. 5 minutes.
it's okay.
Yes,
Ready?
so sorry. Yes.
Okay. Uh, Lumbar spinal stenosis. Patient symptom are best explained by lumbar spinal stenosis, narrowing of the central canal with nerve compression. Common causes degenerative arthritis. We know that. Lower back pain with radiation to buttocks and lower extremity that results in increased compression, nerve compression, neurogenic claudication. It's exacerbated by the extension of the spine during walking downhill or standing. Um, Lengthening of the spinal column with spinal flexion as during sitting and walking uphill, bending forward tends to relieve the pain. The absence of ankle reflexes suggests involvement of the S1 nerve root. Okay, next.
An otherwise healthy 77-year-old woman comes to the physician because of 1 month history of severe dizziness times several times every day. She has the sudden onset spinning sensation and loss of equilibrium that lasts for 20 to 30 seconds. The episodes begin most frequently after she rolls over in bed and turns her head to the right. The episodes begin most frequently after she rolls her over the bed or turns her head to the right. Pulse is 76, blood pressure 140/80. Neurologic examination shows no abnormality. Which of the following is the most appropriate next step?
Ready?
Yes.
So it is positional oculovestibular testing, BPPV, benign paroxysmal positional vertigo. Common cause of vertigo and is best diagnosed with positional oculovestibular testing. BPV occurs when otolith becomes dislodged from the utricle and enters the semicircular canal. Changes in head posture then cause the malposition otolith to move within the semicircular canal, simulating abnormal movements in endoleaf and causing sensation of vertigo. Patient typically report symptoms of intense brief episodes of vertigo that occur after changes in position, such as rising from bed or rolling over, accompanied by visual disturbance such as nystagmus, nausea and vomiting. Um, Positional oculovestibular testing such as Dick's Heartbeat test allows the examiner to reproduce the patient's symptoms by repositioning the otolith. Further, positional maneuvers such as the happy maneuver can be used to move the malpositioned otolith to its proper position within the oticle. Patients with refractory symptoms may benefit from medical management, including scopolamine and mescaline. Snap B tilt table testing or tilting testing is used for diagnosis of orthostasis. While orthostasis may cause position-dependent symptoms of vertigo, syncope, and syncope, these symptoms are more likely to occur upon sudden standing rather than while rolling in bed or turning the head. Okay, next.
A 35-year-old woman has constant burning pain in her right hand, constant burning pain in her right hand since closing her hand in a car in a car door 1 year ago. Examination immediately following the injury showed extensive ecchymosis and swelling. No fractures were identified, but the hand was placed in the cast for 1 month. She is unable to tolerate light touch or any motion of the wrist or finger joints. Examination. Which of the following is the most likely explanation of this finding?
Ready?
1 second. Okay. Ready?
Yes. So it is, what is it? Abnormal sympathetic neural response. Abnormal sympathetic neural response, also known as reflex sympathetic dystrophy or complex regional sympathetic neural response, reflex sympathetic dystrophy or complex regional pain syndrome can potentially occur after traumatic injuries and has variety of clinical characteristics. Commonly, patients will develop pain out of proportion um, to the degree of injury in a distinct anatomic location that does not correspond to a single nerve or dermaton. The exact pathophysiology is unknown, but is thought to involve either changes in central pain processing or aberrant stimulation of damaged peripheral nerves. Aberrant stimulation of damaged peripheral nerves that release inflammatory substances such as neuropeptide Y and substance P. Common clinical manifestations include pain out of proportion to the injury with severe allodynia, impaired muscle strength in the location of injury, autonomic changes including increased sweating and color or temperature changes, and occasionally atrophy and fibrosis. It's not increased carpal tunnel intracarpal canal pressure leads to carpal tunnel syndrome as a result of compression of the median nerve. At the risk, symptoms include paresthesia and palmar aspect of the first two and three digits. The medial nerve fibrosis can sometimes occur following a bone fracture with injury to the nerve and in or after surgical intervention. Symptoms include sensory and motor disturbance in the distribution of the median nerve and depend upon the location at which the median nerve is affected. It's not post-traumatic arthritis, described joint pain that occurs following a traumatic injury to the articular cartilage. Or for joint. Like most cases of steatitis, pain is localized to the affected joint and worsens with activity, but improves with rest. Temperature changes and sensory changes of the skin. Temperature changes, sensory changes of the skin are not seen unless the traumatic injury also resulted in trauma to the local tissues or nerves. Okay.
So complex regional pain syndrome or reflex sympathetic dystrophy, like the main gist is we cannot explain this disease with the single nerve or the pathophysiology through the pathophysiology, like we cannot explain, like uh, if pain happens in the median nerve distribution, then thumb, index and middle finger is involved, but in these cases there is uh, another location is involved, so we cannot tell the story about the actual, like we cannot explain through the single nerve. That's the theme in here in complex regional pain syndrome.
Mm-hmm.
Okay, and there is like more pain than it should be, like this happened 1 year ago but she has still there is pain.
Mm-hmm.
Okay, very complex topic.
Mm-hmm.
There is
Mm-hmm.
another term called SIPA. Do you know that?
Mm-mm. That is it.
Okay, I forgot. Okay, let's
Oh.
start. SIPA is uh you just write SIPA and see the episode of Doctor or like Doctor House, like House MD. Like you are putting pain in somewhere, but he is not feeling the pain. That is SIPA. Like uh, you are stabbing somewhere, or uh, uh, you are okay. Stop. Okay, let's
Okay.
study. We will talk it later. A 25-year-old woman has had generalized weakness for 2 days on questioning. She reports numerous hospital admission for abdominal pain. One episode occurred after treatment of a urinary tract infection with sulfonamide. Examination shows global weakness and areflexia. Babinski sign is absent. Sensation is Sensation to pinprick is mildly decreased in a stocking and glove distribution, and sensation to vibration is decreased over the feet. She has tachycardia and does not show with carotid massage. She has tachycardia that does not slow with carotid massage. Which of the following is the most likely diagnosis? Global scabs.
Ready?
1 minute. Okay.
Okay. So it is abdominal, okay, acute intermittent porphyria. Your intermittent porphyria is most likely diagnosed in this patient with episodic abdominal pain and peripheral neuropathy in the stocking globin distribution, which is caused by Autosomal dominant mutation of the BBGD gene, porphobilinogen deaminase gene. This enzyme catalyzes the third step in heme synthesis, which combines BBG porphobilinogen molecules into hydroxy whatever, which is subsequently converted to porphobilinogen 3. Loss of this enzyme leads to accumulation of BBG, which is toxic to the nervous system. Additionally, increased activity of the upstream enzyme, ALAS, the aminobulimic synthetase, whatever, leads to accumulation of ALA, which is also toxic. The mutation affects both erythroid cells and hepatocytes. The disease manifestations are primarily neurologic and include peripheral neuropathy, bladder dysfunction, autonomic dysfunction, abdominal pain is classic and results often from ileus. The penetrance is low, so family history is not often present, which can lead to delayed diagnosis. Disease flares can occur after exposure to certain triggers, such as certain medications, tobacco, alcohol, stress, and starvation. It is not what's between Charcot-Marie-Tooth disease, genetic disorder that presents with slowly progressive peripheral neuropathy, often in association with foot deformities such as hammer toes and Pescavus. A family history is typical. It is not if leprosy is caused by infection of Mycobacterial leprae and is exceedingly rare in developed countries. It presents with characteristic skin findings in conjunction with peripheral sensory neuropathy, commonly involving the ulnar, median, radial, and peroneal nerves. Paraneoplastic neuropathy is most commonly peripheral sensory neuropathy that is related to an underlying systemic malignancy and is often secondary to production of antibodies. This patient has no evidence of cancer. Next.
Okay. A 62-year-old woman comes to the physician because of 6-week history of stiffness and pain of her neck. Stiff 6-week history of pain of her neck, shoulders, and hips. Pain, shoulders of hips. She has difficulty dressing herself and combing her hair in the morning. She has had generalized weakness, malaise, low-grade fever. She has 2.3 kg weight loss during the past month despite no changes in the diet. She has no history of serious illness. Her only medication is occasional acetaminophen for pain. Vital signs are within normal limit. Examination show pitting edema of the hands and the dorsal aspect. Pitting edema of the hands and the dorsal aspects of the feet. Range of motion of the range range of motion of the neck, shoulder, and hip is limited. RESR is high. Additional lab findings include her serum TSH concentration is within normal range. X-ray of the shoulder show uh, fit no abnormality. Which of the following is the most likely diagnosis? Ready?
One moment. Muscles, stiffness, weakness. Hmm. Between polymyalgia and polymyositis. Polymyositis was muscle weakness, and I think polymyalgia was muscle stiffness. So which one is it? Yes, that is I.
Yes, sir. CRP is high in PMR, but CK should be raised.
Yeah, so it's probably about the PMR. Okay. It is PMR. Polymyalgia rheumatica is inflammatory condition in which aching and stiffness, so pain and stiffness develop in the shoulder, hip, and neck. The most common risk factors are age more than 50. Being female, it's also frequently associated with giant cell or temporal arthritis present with unilateral headache and vision loss if untreated. Other inflammatory signs such as malaise, fever, and are often present, though localized muscle weakness is not typically seen. Lab demonstrates increased inflammatory markers, thrombocytosis. PMR is responsive to steroids, which are third line. Low dose prednisone is treatment of choice. It's not polymyositis, autoimmune inflammatory myopathies, characterized by muscle weakness rather than stiffness, proximal muscles. Okay, yeah, okay.
If
Next.
it, a 57-year-old woman comes to the physician for 8 months, because of daily headache for 8 months, the headache are localized to the right temple. The headache are localized to the right temple, usually worsen throughout the day. At times, the headache are exacerbated by chewing. At times, the headache are exacerbated by chewing. He has a history of migraines, but has not had one since menopause 6 years ago. She recently divorced and is under a great deal of stress at work. She has smoked 1.5 pack of cigarettes daily for 15 years. Her temperature is 37, pulse 82, blood pressure 148 by 86. Examination shows pain with movement of the jaw and tenderness under the right zygomatic arch. The nasal mucosa is normal. A ESR is 20. Which of the following is most likely diagnosis?
My pen. What the hell?
Ready?
One moment. Okay, ready.
Okay.
It is temporomandibular joint syndrome. TMG forms the articulation between mandibular condyle and the glenoid fossa of the temporal bone. TMG syndrome occurs because of combination of structural damage to the TMG and a variety of neurologic and physiologic and psychological factors related to the pain and stress. Patients usually present with unilateral dull, occasionally sharp or stabbing pain near the TMG or anterior to the auricle that is exacerbated by chewing or jaw clenching. Patients may also experience popping or clicking sensation associated with movement of the jaw and decreased range of jaw motion. Treatment includes physical therapy, cognitive behavioral therapy, or um, biofeedback therapy to treat underlying stress, and pharmacologic therapy, including NSAIDs or TCAs. It is not was between trigeminal neuralgia. It's also known as tic douloureux, presents with brief, recurrent, sudden episodes of pain in the distribution of the trigeminal nerve. This is typically triggered by minor stimulation of the affected area, such as light touch, cold air, talking, brushing one teeth. Patients often describe the pain as sharp, stabbing, and electric. Okay, next.
Yeah. If a 42-year-old man comes to the physician. A 42-year-old man comes to the physician with his wife because of 6 month history of increasing clumsiness, 6 month history of increasing clumsiness, and a 1 month history of irritability. His wife has noticed jerkiness of his limbs when he walks downstairs and walks quickly. During the past month, he has had the same involuntary movement at rest after stressful days at work. She has not had fever, chills, night sweat. He does not smoke cigarettes, drinks alcohol, use illicit drug. He goes he goes camping several times yearly. He does not appear to be in distress. Examination shows involuntary movements of the right upper extremity, while the patient is able to suppress when made aware of them. His gait is ataxic. His gait is ataxic, and additional testing is more likely to show which of the following abnormalities. What is your diagnosis?
I don't know. I
Is
thought
it
Parkinson, but
but Parkinson is not at that age, and
yeah,
Parkinson is resting temper, not
yeah,
involuntary movements.
yeah, or
Is
another.
it Huntington?
Oh, oh,
Huntington cause ataxic gait, 1 point, and another is involuntary movement at rest and after stressful.
oh,
And
oh,
what what is what is your differential like apart from Parkinson? I'm
yeah,
thinking about Huntington. I
yeah,
don't know.
probably Huntington or the tremors, the essential tremors, and all these things. But yeah, probably Huntington, like you said.
Okay.
If it's Huntington, then it's probably the caudate nucleus. Anyway, ready. It's the caudate nucleus. You're right. It's Huntington. Atrophy of the caudate nucleus on brain imaging would be expected in this patient who most likely has Huntington, a progressive neurodegenerative condition that arises from misfolded proteins as a result of nuclear expansion in the Huntington gene. What is the expansion in Huntington? Is it CAG?
Yes.
Okay, good.
Trinucleotide repeat expansion. CAG,
Patients,
like hunt means can't aim great. Then you can easily remember. Like what hunter does. They actually aim. You got my point.
no.
CAG. If we elaborate this thing like can't aim great, like what the hunter does, like hunter hunt the animals and their aim should be great, but
Okay,
this hunter is like me, can't aim great.
okay. I got it. Okay.
Now you
Right.
can remember the CAG.
Nice. Patients develop coriform movements which are characterized by involuntary flailing motions of the upper extremities. Eventually, these motor disorders, including ataxic gait, will interfere with daily life. Concomitant Disturbance such as emotional liability, anxiety, depression, and psychosis may also occur later in later stages of the disease. Many patients exhibit a family history of similar symptoms, but the disease can also be de novo. Since this is autosomal dominant, there is 50% chance that affected individual will pass it to the baby. Dissipation whereby symptoms manifest, blah, 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 is also typical in this disease. It is not oh, what is here? Dilated ventricles on brain imaging are seen in patients with hydrocephalus, which can either be communicated or non communications. Patients can present with headache, nausea, vomiting, instability, but would not cause coliform movements. Okay,
Next,
next.
a previously healthy 82-year-old man is brought to the emergency department because of 3 hour history of difficulty communicating. 3 hour history of difficulty communicating. His wife reports that when he when he awoke this morning, he seemed slightly confused. He seemed slightly confused uh, and did not make sense. Seemed slightly confused and did not make sense. He has hyperlipidemia. Treated with simvastatin, he does not appear to be in distress. He is 170 centimeter tall. Weight is 100 kg. BMI is 35 kg per meter square. BMI is 35 kg per meter square. Uh, his temperature is 37 degrees Celsius. Pulse is 85 per minute. Irregular. Pulse is 85 per minute. Irregular. Respiration is 15 per minute. Blood pressure is 145 by 90. Examination shows mild pronator drift. During the examination, he is attentive but has some difficulty naming objects correctly. Difficulty naming objects correctly and following two steps commands. An ECG show atrial fibrillation. Which of the following is the greatest risk factor of a neurologic condition? Difficulty naming object. Greatest risk factor. Hmm, okay. Ready?
Yeah. So it's dysarrhythmia, the acute onset of focal neurologic deficits, motor weakness, um, confusion, dysphagia is concerning for thromboembolic cerebral infarction or stroke. AFib is a major independent risk factor for stroke, and stroke prevention is an essential aspect of management. The loss of coordinated atrial contraction in this arrhythmia results from blood stasis within the atrial compartment and promotion of thrombus formation. Embolism to the cerebral arteries result in ischemic stroke. The presence of right-sided hemiplegia and expresses dysphagia are suggestive of a lesion involving the left middle cerebral artery distribution. The middle cerebral arteries are the most common cerebral arteries involved in acute thromboembolic stroke. Next.
A, a 77-year-old man is brought to the physician by his daughter because he has become increasingly forgetful during the past 6 months. His daughter during the past 6 months His daughter states that his short-term memory is quite impaired, and he says that he is frustrated with his memory. He lives alone and is able to perform activities of the daily living independently. On questioning, he reports 1 month history of mild non-productive cough, constipation, mild pain in his hips with movement, and mild numbness of the toes of both feet, and few episodes of urinary incontinence. He has hypertension, hyperlipidemia, and well-controlled type 2 diabetes mellitus. Current medication include metformin, lisinopril, atorvastatin, aspirin. His wife died 6 years ago. He does not smoke or drink alcohol. His temperature is 36.8 degrees Celsius, pulse is 72 per minute, respiration 14 per minute, blood pressure 128 by 72 millimeter mercury. Muscle strength is normal, cranial nerves are intact, deep tendon reflex and normal to sensation to vibration is mildly decreased over the distal lower extremity. Sensation to mildly decreased over the distal lower extremity. Proprioception is intact. Proprioception is intact. His gait is wide based and he has not impaired tandem walking. His gait is wide based and he has impaired tandem walking. His mini mental status examination is 24 by 30. He recalls one or three objects after 5 minutes. An MRI of the brain show enlarged ventricle with minimal cortical atrophy. Enlarged ventricle with minimal cortical atrophy. Which of the following is the most appropriate next step in the management? Wide base impaired tandem. What is your diagnosis?
Oh no, I don't know. I don't have a diagnosis here.
Memory problem, urinary incontinence, ataxic gait. Now,
Oh, do you think it's what is it? Not the
NPH,
non-pressure hydrocephalus. Mm,
because MRI show enlarged ventricle.
silent, yeah. But still, what would you give that? Oh, lumbar puncture. Uh-huh. Okay, yeah, it's probably lumbar puncture. Okay, ready?
Yes.
Mhm. It's lumbar puncture. The patient is presenting with findings concerning for normal pressure (MPH) with a characteristic combination of dementia, gait instability, urinary incontinence. MPH refers to a type of communicating non-obstructive hydrocephalus in which the ventricles are enlarged, leading to damage of the white matter tracts connecting the frontal lobes and basal ganglia. Signs of increased intracranial pressure like papilledema, postural headaches are typically absent. Hmm. Many cases of MPH are idiopathic, though some are secondary to a defect in the CSF in CSF drainage from the ventricles as a result of scarring or obstruction of the ventricular lining from prior hemorrhage of meningitis. Diagnosis is primarily clinical, although ventriculomegaly on brain imaging is suggestive. The most appropriate next step in management is a lumbar puncture to assess the opening pressure in clinical response to removing CSF. Placement of ventricular shunt may be needed for long-term management. And it's not additional nepesi may be considered in the future if the patient cognitive symptoms don't improve. Best initial test step is management of this patient. For this patient is to perform a lumbar puncture and assess his clinical response to the removal of CSF. So you say it was ventriculomegaly, urinary incontinence, and gait stability. That's what you said. Those were the main signs.
Okay.
Hello?
Yes.
Oh, oh, I was asking. Sorry.
Sorry.
No, I was asking. You said the main signs were ventriculomegaly, urinary incontinence, against gait stability.
Yes.
Okay, next.
A previously healthy 42-year-old man comes to the physician because of 6 week history of intermittent pain and tingling that radiates from the right shoulder blade to the right thumb index finger. These symptoms worsen with coughing and sneezing. There is no history of neck pain, shoulder, or arm injury. His pulse is 72 per minute. Blood pressure is 120 by 70 millimeter of mercury. Physical examination shows no abnormality. The cranial nerves are intact. Muscle strength is normal in all extremities. Deep tendon reflex are 1 plus in the right biceps muscle and 2 plus in the elsewhere. Babinski sign is absent. Uh, Sensation to pinprick is decreased over the dorsal aspect of the right thumb and index finger. Which of the following is the most likely mechanism of these patient symptoms? Right. Ready?
No, one moment. Radial nerve compression of the spiral groove. Labyrinth, no. Cervical nerve root compression. Probably. Brachial plexus compression. Ready.
Yes.
Okay. So is cervical nerve root compression. Shit. Cervical nerve root compression experiences patient symptoms of cervical radiculopathy. Cervical radiculopathy refers to pathology affecting a specific spinal nerve root that leads to weakness, numbness, paresthesia, and pain in the dermatomal and myotomal distribution that correlates to the affected root. C5 radiculopathy will result in pain that radiates from the neck into the arm, along with decreased sensation to pain and paresthesia in the lateral forearm and the lateral two digits, C5, C6. Additional C6 radiculopathy causes motor dysfunction of elbow flexion and waist extension. Okay. And diminished or absent biceps reflex. Radiculopathy symptoms may worsen with activity that increases pressure, such as coughing and sneezing. Radiculopathy may be caused by spondylosis, degenerative changes of the spine, disc herniation, infection, tumor demyelination, or infarction. Dermatomes and myotomes are components of the embryonic somite. whatever. When fully developed, dermaton is an area of skin whose afferent fibers travels within a single spinal nerve. Myotom is a group of muscle innervated by the afferent fiber of a single spinal nerve. It's not brachial plexus compression typically presents with weakness, numbness, and paresthesias of the anesthesia of the majority of the upper extremity. Brachial plexus compression typically affects multiple nerve roots, and motor dysfunction typically predominates over sensory dysfunction. And pain early in the disease process. Okay,
Next.
next.
A 67-year-old man with hypertension is brought to the emergency department 30 minutes after a stroke. Examination show Horner syndrome and paralysis. Examination shows Horner syndrome and the paralysis of the palate. On the paralysis of the palate on the right, sensation to sensation is decreased. Pain over the right side of the face and the left side of the body. Sensation is decreased to pain over the right side of the face and the left side of the body. Sensation is absent to hot and cold over the right face and the left side of the body. There is no paralysis to the extremities. Which of the following is the most likely diagnosis? Ipsilateral face, contralateral body.
Mm-hmm. Lateral medulla, right thalamus.
Ready?
One moment.
Yes.
Thalamus, mid medulla. Okay, ready. So it is right lateral medulla. Is it what I choose? No, it's not what I choose. Right lateral medulla. Lateral medullary Wallenberg syndrome is caused by occlusion of the posterior inferior cerebral artery, leading to a ischemic stroke of the lateral medulla. Five.
Wait 1 second. I'm calling.
Okay. Okay. Lateral medullary Wallenberg syndrome caused by occlusion of the pica, leading to an ischemic stroke of the lateral medulla. Five main structures are affected, which include nucleus ambiguous, vestibular nuclei, lateral spinothalamic tract, spinal trigeminal nucleus, sympathetic fibers, and inferior cerebellar peduncle. Loss of the nucleus ambiguous leads to dysphagia, decreased gag reflex, and hoarseness. The vestibular nucleus loss causes vomiting, vertigo, and nystagmus. Contralateral body and ipsilateral face will develop decreased pain and temperature sensation from involvement of the lateral spinothalamic tract. Horner syndrome may also result in what am I? In if may also result if the sympathetic fibers are damaged. Additionally, ataxia and dysmetria from the involvement of the cerebral peduncles will also be present. However, a patient with lateral medullary syndrome may not necessarily have demonstrate all of these findings in equal proportion as in this case. It's not infarction of the right thalamus may develop from occlusion of one of four different arteries: the tuberothalamic artery, paramedian artery, inferolateral artery, or posterior choroidal artery. Depending on the artery involved, symptoms may range from cognitive behavioral disturbance and memory deficits to sensory impairment and visual defects. When the right thalamus is involved, hemi neglect is typically also present. Okay, okay. Can we stop here today?
Yes, we can. I'm
Okay.
extremely